purpose of my presentation today is on this aspect of emergency care, because if this doesn't is not done very well, then majority of patients will not actually get to the emergency department. And for me, I think that has been my biggest passion towards building an emergency care system, because in our setting here in Kenya, for example, majority of patients who have emergencies do not actually make it to the emergency department. Those we see in the emergency department are those who have actually survived all the way to get the emergency department, and there are a bigger chunk of patients who, if handled properly from the pre-hospital setting and if got too early, then we'll be able to actually save more lives. And that's my passion, to look at seeing how do we improve on the pre-hospital aspect of emergency care. As I said, it's just very evident from the screen is emergency care is not just the emergency unit. That's a small part of it. All starts from the scene and from the road. All right, so I know, just so that we are all on the same page about the situation in Kenya and some of the things that we really need to look into as a country. Um, so with 911 does not work in Kenya, not for ambulance services. 911 is a police number. So if you call 911, you'll get the police. So we do not have a national short code public ambulance access number. The Europe has 112, the West has 911, I think Australia has it as 999. But for Kenya, what we have different ambulance companies, mostly private, that you have to call directly to access a number. And yes, so well, we may not necessarily be always calling mom when you have an emergency. What is currently happening is a couple of counties across the country are actually building dispatch centers and building ambulance systems. So if you're out there in the different counties, you may need to check in with your county government what's going on, because some of them are actually doing some amazing work trying to build ambulance service systems within the county system. So while we don't have that national part of it, and it's work that we really are focusing on, it is work that some people are already doing um, and working on. So, and just to highlight this and put it simply, this is not an ambulance. This is a vehicle, looks like a van with a bed in it, maybe a longboard there, but no, that's not an ambulance. This is an ambulance, okay? So an ambulance has equipment, an ambulance has medical devices, an ambulance can save a life, okay? So an ambulance is not merely a transport vehicle, it's not a matatu with sirens or pickup with sirens, okay? So an ambulance is a well-kitted mobile emergency department, and actually in certain centers, and I'm sure Florian in his center, they have what we call mobile ICUs. So it's actually can be kitted to be a full emergency department, can be kitted to be an ICU setting. So yeah, so what we have, this is not an ambulance. This is a vehicle that has a bed in it. You can call it a mobile hotel room, but it's not an ambulance. An ambulance needs to have kits and needs to have proper equipment. We actually have standards in the country for ambulance services. The Kenya Bureau of Standards released guidelines. The latest edition is 2019. And these guidelines provide minimum local requirements in terms of vehicle design, ambulance personnel, medical devices. So again, as contrary to common belief, ambulances are not those vehicles that have sirens that carry charcoal. Ambulances are not those vehicles that carry other illicit drugs in between. Ambulances actually, it's mobile healthcare with trained personnel, appropriate equipment that is life-saving equipment, and of course has the design that is allows you to move a patient safely from point A to point B. So check out the KEBS website if you want to um, find out more about the standards. But more importantly, next time you come across an ambulance or you're working an ambulance, my question to you is, does your ambulance meet KEBS standards? If not, then you should probably rub ambulance and write something else next to it, because an ambulance is a very well defined vehicle. So other thing that's just to highlight, so the healthcare provider on the left is probably a nurse. A nurse and an EMT are not the same, okay? Nursing training is focused on providing care in a hospital setting. From all the different meetings I've had, I've not encountered any nurse who's told me that part of their training was in an ambulance. There are nurses who have, I can say, have gone the extra training to become EMTs and paramedics, but a basic nurse is trained to work in an in-hospital setting. So a lot of people, I know in Kenya, periodically, once in a while, you'll hear that the nurse and and the driver were at the front and the patient was at the back, and we'll always want to say that's wrong. But the nurse was not trained to work in a moving vehicle with a sick person in it. So there actually are EMTs. So an EMT or a paramedic is a trained, certified pre-hospital, you'll actually say emergency healthcare provider, because they actually receive extensive amount of training on working. As you can see in the space, which is a friend of mine called Brian, you can see the space in which he's working. That's his office. That's what he was trained to do, and that's where he will normally be working from. And he has the necessary knowledge, skills, and expertise to handle any emergency in this setting, okay, which is a bit different from other normal healthcare providers who, even for doctors, we are trained to handle emergencies in an in-hospital setting. So not many of us are able to comfortably transition and work and operate in a moving fluid environment. And there are a few other aspects we'll look at it as we go through the presentation that show you what different environment pre-hospital healthcare providers work in, and why it's important that they receive appropriate training to work in that environment, because it's not the easiest environment to work in. If you've never been in an emergency, in an accident scene while it's raining cats and dogs, and you still have to provide emergency care by the roadside, then it's not everyone's cup of tea. So those are just some of the key things highlighting what an EMS service is. Just, I'm sure those EMS providers on this call, on this webinar, will appreciate that they do quite a lot for the hospital, for the healthcare system, especially in the pre-hospital setting.
I have a priority 1. Suspected head injury secondary to a high-speed hit and run. Unresponsive adult male, about 20 to 30.
Might have traffic up ahead.
We need to know where you are. Okay, Esther, you have to slow down. Just take a deep breath. Now tell me, what happened?
So what do we have?
Pedestrian involved in a high-speed hit and run.
How long ago?
That's all we have.
My name is Zach from Raven Paramedics. Sir, I'm with the ambulance. We're here to help, okay? Raven Paramedics were expected.
We don't have an ICU bed.
What? We have a patient who's in dire need of emergency care.
All our 21 beds are fully occupied.
We need to get moving and get to a hospital with working doctors.
You need to sign off this patient to a hospital. Trust me, you don't want your name in the news with blood on your hands.
How many lives do you think I've saved before? Do you count? I don't know. Exactly my point. Many.
Kwani Mungu ako wapi? I don't want his will to be done. Kama your will ina take away what matters to me.
I am not giving up, and I am not asking you to.
You can treat my husband. That is the least you can do.
I'm a paramedic. I know my job. No entry on the left side.
He has internal bleeding on the left side of his brain.
Say something!
8, 9, 10.
Here.
All right, so that's just a sneak preview of a movie we're involved in some years back, 18 Hours. You should look for it. It's a fantastic movie by Rock Pictures, highlighting what paramedics in Kenya go through every day, and gives you a good picture about what EMS services looks like, especially in our setting. And yeah, so catch it. I'm sure it should be somewhere online. I think Showmax has it. All right, so what are the key things that are important for you in working in a pre-hospital setting? I think if there's one place where safety is a key discussion is in the pre-hospital setting. And because 99.9% of the time the environment is uncontrolled, the events are acute and there's a lot of tension going on. It's strangers all around you. And again, if the scene is not safe, then you are also not safe. So safety is one of the key, most important parts of pre-hospital care, and it's all starts from your safety as a pre-hospital provider, scene safety, ensuring that you have access to the patients in a way that you will not also be part of the accident scene, for example. But a lot of it, people again think about safety from the perspective of a road traffic accident. But if you were, for example, as an EMS, and this has happened in many EMS services that I know of, where you're called to respond to maybe a gunshot victim in a gang area. So a lot of factors come in place there. So you could easily be shot because EMTs are not bulletproof, and the environment may not necessarily be safe. So it's not always just about the road traffic accident scene, but even safety coming to your neighborhoods, coming to your houses, and that becomes a key thing for any EMS provider. So your safety is always priority as a pre-hospital healthcare provider. Scene safety, so scene could be a road scene, could be someone's house, could be an bomb blast, for example. I think when we had the Dusit attacks, safety was one of the first things that needed to be secured before any of the victims were attended to. And then there's also the patient safety, because again, patient safety comes from the perspective of you have to extricate this patient from their environment, put them in a moving ambulance that potentially is moving at very high speeds, and you could easily crash the ambulance, which has happened, and the patient may have survived the acuteness of their illness, but they died in a road traffic crash. So that is also very something to really look into. And then there's bystander safety, because of course there's always onlookers and people who crowd around in any. The lights and sirens are very fancy and they attract a lot of attention. And this can also be a situation where bystanders get affected in case something happens. So I think I cannot emphasize in any situation, if you are ever working in a pre-hospital environment, the first and most paramount thing for you to look into is safety. So before you do anything, your safety, scene safety, patient safety, and bystander safety. Another important aspect of pre-hospital care is what you actually see at on the screen here is most of the times you may not necessarily be dealing with one patient. You could easily come in as an EMS crew. You've been called into a bus crash. So this was not actually a bus crash. A bus has 30 people, plus the driver of the trailer and his boy. So that's 32 people. So you have 32 victims, and you're only seeing on this video, on this screen, you have two EMS or three EMS providers to handle 30 people at the same time, with everyone having an equal chances of dying. So one key aspect that EMS providers must be proficient in, and they practice this over and over and over through the drills, is triage. There are different triage processes, there are different triage protocols. I like the SALT triage. It's easier to remember and easy to walk through. And but there's Jumpstart for pediatrics, there's Start Triage. So the key important part is you must have a triage system that's known by you and your service. And again, if it's in, for example, a county setting or a regional setting, then it's the same triage system that we are all using. But most triage systems essentially end up roundly really much the four colors. So either you're a green, yellow, red, or black, if you're dead, that is. So in any mass accident scene, the first part of it is get rid of or move away. No, I won't say get rid of. Is move away any of the patients who can walk. So as you can see, so step one is sorting out. So if you can walk, go to that side. If you can wave at me, go to that side. If you are not moving, then I need to worry about you. So those who can walk, move away. So you will first, and in many accident scenes, the majority of the patients are the what I'd call mildly wounded patients who do not need life-saving interventions at that particular point. They may have wounds or are in no immediate danger, so that group of patients needs to be moved. Now, whoever is left, then you need to go through the assessment, and the key life-saving interventions are controlling any major hemorrhage, open the airways if that will help them breathe. If they're not breathing, then they definitely are dead. If they start breathing, or in a child, you need to give to rescue breaths. If they're breathing, then the next thing is, are they able to obey commands, any purposeful movements, the pulse is present, not in respiratory distress, major hemorrhage has been controlled. So bleeding, bleeding, bleeding. This is, I think, in a pre-hospital setting, the one more important part in any setting is, if they're bleeding, stop the bleeding. Okay, so that's normally a priority in any of your assessments of your patients. Any bleeding has to be stopped, and then they can do interventions like chest decompression and things like that. And if your patient meets all these criteria and only has minor injuries, then they're minimal, they can be dealt with last. But if they have more than minor injuries, then they can need to be dealt with. But any of those who are not obeying commands, no peripheral pulses, um, and potentially in respiratory distress, then the question is, are they likely to survive? If yes, within the resources, if yes, then you need to immediately manage them. If the survival is minimal, then you put them in a category called expectant, where once you've dealt with the immediate cases and potentially the delayed cases, then you can deal with the expectant cases as you move down to the minimal cases. But triage is about triaging the patients on scene to prioritize who needs immediate care, but also triaging to prioritize who needs to get to the hospital faster. So a lot of times, and this actually happened in the last mass casualty incident there was, is normally in an accident scene or in a scene where many patients are there, those who are who have minor injuries will be the first ones to run to the ambulance and get into the ambulance and demand to be transported. Now, what happens is, once you move this group of patients in your ambulance, then all the sick ones are left on scene, and they are the ones who are at highest risk of dying. These are the ones, even if they were transported many hours later, they would still have been fine. So always prioritize. So triage is about identifying quickly who is a red or a yellow patient, and also prioritizing their transport to the nearest, most appropriate healthcare facility from the scene. So one thing that definitely as we look at even how we respond to mass casualty incidents, is the green people need to come last, not first. And this needs to be prioritized. And this is something the pre-hospital system and the EMS providers I know are very proficient with. So in terms of other assessments, I'm not really going to go, because a lot of this we captured through the adult emergencies and pediatric emergencies. So I'll just give a quick overview where there are potentially some differences in the pre-hospital setting. But the ABCs are ABCs. The patient is the same. It's just potentially what you have is a bit of a limitation of what you can do in a pre-hospital setting. But for the CABCDE, majority of which pre-hospital providers are able to do. So the first one, so they have two things to look at, is doctor CABC. So doctor means danger. This is where the safety discussion was coming in. So ensuring you're safe, and then is your patient responsive, which is the same discussion we're having about triage process here, where is your patient making any purposeful movement, or do you need to resuscitate this patient? And if there's a group of people who have very well trained in resuscitation, is your EMS providers. And in many settings, the EMS providers actually do also work in the emergency department, because they are the ones who do the best CPR and best ventilation. Well, the rest of us watch them. Yes, but anyway, so your EMS providers normally are very well trained in resuscitation. So again, the first thing is, I said, catastrophic hemorrhage. Stop bleeding, stop bleeding, stop bleeding, stop bleeding. I don't think this can be emphasized as much enough. The priority is, so first danger, check responsiveness. If there is any catastrophic bleeding, you need to stop bleeding.
Life-threatening bleeding or hemorrhage requires immediate attention and treatment. Life-threatening hemorrhage can lead to death within minutes if the bleeding is not stopped. If the casualty is suffering from life-threatening blood loss via the limbs, use a tourniquet to stop the bleeding and control the hemorrhage. A tourniquet is basically a tight binding that cuts off blood flow and stops life-threatening bleeding. Cautionary note: a tourniquet is never to be used for wounds on the head, neck, or torso, which would cut off circulation to the brain and vital organs. Commercial tourniquets may have their own specific instructions, but they generally follow similar guidelines. While preparing the tourniquet, use direct pressure or apply a pressure point to immediately slow down the bleeding and begin controlling the hemorrhage. Apply the tourniquet approximately 2 to 3 inches above the hemorrhaging wound of the arm or leg. Ideally, it should be placed directly on the skin, but if there is potential danger at the scene or other factors that prevent proper treatment, placing the tourniquet over clothing may be adequate. Do not place a tourniquet on a joint, below the knee on the shin, or below the elbow on the forearm. The bones of the shins and forearms can splint the hemorrhaging blood vessels and make it impossible to control the bleeding. Apply the tourniquet tightly enough to block life-threatening blood flow. This may be very painful for a conscious casualty, but do not stop tightening until the hemorrhage is controlled. Once the tourniquet is applied, check to make sure that there is no pulse on the limb. If a pulse is present, that means the tourniquet is not tight enough. Tighten it further until there is no pulse on the limb. Generally, the bigger the limb, the tighter the tourniquet must be, so the leg will require more pressure to control bleeding than the arm. Once the scene is safe, reassess the tourniquet's application. Ensure that the tourniquet is placed 2 to 3 inches above the wound, directly on the skin. After application, leave the tourniquet exposed at all times that it's applied. It may be necessary to use more than one tourniquet to control severe bleeding. If needed, a second tourniquet should be applied just above the first, that is, closer to the heart along the limb. If possible, try to maintain a record of when you applied the tourniquet and keep that record with the casualty if and when they are evacuated. Remember that a life-threatening bleed that is located on the head, neck, or torso cannot be treated with a tourniquet. Such injuries may require the combined use of hemostatic blood clotting gauze, direct pressure, and pressure dressings to control the bleeding. Non-life-threatening wounds should also be treated with this combination. The steps for using these techniques are outlined in a separate video.
All right, so I think stopping catastrophic hemorrhage is always a priority in a pre-hospital setting. And the tourniquet can be used, you can either use a commercial available tourniquet, a tie, a belt, triangular bandage that's rolled up properly can be used. The key thing is stop the bleeding by all means necessary. So after catastrophic hemorrhage control, the other thing you're looking at is airway. Airway with C-spine control, and so does your patient have a patent airway? Can they maintain their own airway? Do you need to add devices to it? And again, a lot of these devices, a lot of them are also used in the pre-hospital setting to keep the airway open and maintain a patent airway to get the patient to the hospital.
It takes at least 2 people to remove a helmet from a patient while maintaining the patient's head and neck in a neutral position. One person stabilizes the patient's head and neck from the head of the bed by placing one hand on either side of the helmet. This position prevents slippage once the helmet strap is loose. The second person loosens the helmet strap at the D-rings or fastener. If the helmet has a face cover, that must be removed first. Then they place one hand anteriorly on the patient's mandible at the angle, with the thumb on one side and the fingers on the contralateral side. With their other hand, they apply pressure from under the patient's head at the occipital region, taking care not to flex or extend the neck. This maneuver transfers the responsibility for inline immobilization to the second person, who is at the side of the bed. The first person at the head of the bed then expands the helmet laterally to clear the ears and carefully removes it. If the helmet provides full facial coverage, the patient's nose will impede helmet removal. To clear the nose, the helmet needs to be tilted backward and raised over the patient's nose, taking care not to bend the neck. During this process, the second person maintains inline immobilization from below to prevent head tilt. After the helmet is removed, inline manual immobilization is reestablished from above, and the patient's head and neck are secured.
Okay, good. So for you to access the airway, I think with our number of borders across the city here in Nairobi and actually across the country, most of the road traffic accidents maybe a border, and most of them potentially, hopefully, they have a helmet on, which is the recommendation. But we all know majority don't. But helmet removal is a skill that you actually need to know how to do purely because you risk injuring the patient's neck by removing the helmet in an improper way. So for you to access the airway, the helmet has to come off. Okay, so to remove the helmet, I think that video is a very clear video of how to control the neck to prevent the patient's head just banging back on the ground once you remove the helmet, and preventing further injury to the C-spine. So airway is always with C-spine control, and for C-spine control, you really need to be able to remove the helmet and provide inline stabilization of the C-spine. So the other skill that I will be demonstrating in the next video is pretty much some of the basic airway skills that every pre-hospital healthcare provider must know, and of course, similarly, anyone working in the emergency care setting should be able to know the same skills.
Hello, my name is Gabriel. I'm a student paramedic at the University of Greenwich. We are currently at the Medway campus, and today I'll be showing you basic airway management. As you can see over here, we've got your OP airways and your NP airways. We do have a bag valve mask set up here. Our suctions, both battery operated and manual. And we have our mannequin over here. So initially, when we arrive on scene, the first thing we do is we follow our primary survey, which is Dr. ABC. Dr. ABC is the acronym for Danger, Response, Airway, Breathing, and CPR. As a danger precaution, first on scene, we always make sure that there is no danger to us, to other people, and lastly, the patient. As a response, we follow the acronym AVPU, which tells us how alert, how verbal, if the patient responds to pain, or if the patient is unconscious, which leads us to A. A is our airway. As airway management goes, there is basic and there is advanced. Today we'll be discussing the basic. Once we've established that the patient is unconscious, we will check the airway. Now to do so, there's either the head tilt chin lift, which is you basically place your hand on the patient's forehead and 2 fingers under the jaw. And what we do is we tilt and we open up that jaw. We have a look inside, and if there's anything we do need to remove, then we will use our 2 different suctioning methods. In the case of spinal injury, and we do suspect spinal injury, we do what is called a jaw thrust. To do a jaw thrust, you use these 2 fingers on the bone of the jaw and your palms on the cheekbones. And all you are doing is lifting the jaw upwards to create a patent airway. This leaves the spine intact, and if there is any spinal injury, then you do not make the patient worse. When it comes to OPs and MPs, we will be using the head tilt chin lift method. To size up an OP, what we do is we put the bottom of the OP to the back of the bone, and we size it up to the top of the lips. It needs to be level, okay, and not higher. If it is too high, then we will oversize the OP, and if it is against the teeth or lower, you will undersize. The way we insert this OP is we make sure that the head tilt chin lift is in place and the OP fits in and rotates naturally, following the top palate of the mouth. It does this to secure the teeth and the tongue creating a direct patent airway. When we use NPs, it is the same size up. This is from the middle of the earlobe to the tip of the nose. As you can see, this MP has a bevel, and this bevel is directed towards the septum. Now, because the nasal passage is very vascular, if you do come across resistance, it is best not to continue pushing for further, as you will create active bleeding. So in this case, we are doing 2 NPs and an OP. Now we will be using our bag valve mask to oxygenate the patient. This is done by using what we call a C grip, where these 3 fingers are placed along the jawline as so, and a C is done to create a seal around the mouth and the nose, and oxygen is pumped directly into the lungs. In the case that the patient does require suctioning, we will be using the electrical or the manual. To do so, we turn the electrical machine on. It has a valve over here to create a vacuum. It is important that when you insert the suctioning unit, you do not cover the hole until you're in the mouth. Once you're in, then you create a seal, create a vacuum, and you suction in a figure of 8 outwards. Never suction further than what you actually can see, as this will cause problems later on if you lodge something further in. With the manual, then it is just the same, using the hand pump, suctioning out for not more than 30 seconds. And that is our basic airway management.
All right, good. All right, so again, basic airway management, every EMS provider must be able to handle a basic airway management and be able to provide ventilation for your patient. So bulk of it again is, as I said, most of the other stuff is pretty much the same in terms of you need to ventilate the patient, you need to check if you need to do a chest decompression, the same as what we do in the hospital setting. For circulation, being able to set up your IV accesses, set up some fluids running, giving tranexamic acid where there's bleeding and if it's allowed by protocol in your setting, checking a GCS, checking your sugar, and correcting hypoglycemia, similar in an in-hospital setting. I said all of this were covered in our previous presentations. And of course, exposing the patient, looking for other injuries, keeping the patient warm. Again, all of this captured in the previous presentation. So they don't really vary that much in the pre-hospital settings as you're doing it in a more uncontrolled environment. So once you've gone quickly through your ABCs, and sometimes even before you go through your ABCs, there's a key important part is about extrication and safely extricating your patient and packaging your patient for transportation to the nearest facility.
My name is Adam Gallegos. I'm a firefighter paramedic with the Castle Rock Fire and Rescue Department. Today we're going to be going over rapid extrication scenario. First and foremost, we want to make sure that we have our BSI on, gloves, eyewear. You can wear these into the scenario or you can also verbalize. First, we're going to apply the collar. Prior to doing that, we're going to have my partner Joey maintain inline manual stabilization. He's going to ensure that there's neutral alignment of the spine. If he needs to open the airway or adjust the airway, he's going to use the jaw thrust maneuver. And we'll instruct one of our other responders to check the patient's sensory, circulation, and motor. So Joey's going to size the collar. In order to do that, he's going to, again, maintain neutral position of the spine. He's going to ensure that the ears are in line with the shoulders and the eyes are 90 degrees to the torso. Joey's going to measure from the bottom of the chin to the top of the shoulder, using his fingers for the width. He'll preform the collar prior to putting it on, ensuring there's a natural bend of the collar. Slide the collar along the chest and then slide the back of the collar behind the posterior part of the patient's neck. He'll attach the strap, and if this collar is fitting appropriately, the chin cup will fit snugly against the bottom of the patient's chin. Now we're going to perform the actual extrication. Rescuer 1, Joey in the back here, is going to maintain manual stabilization of the spine. Rescuers 2 and 3, Jay and Lieutenant Richardson, are going to support the patient's hips as we move him. And Rescuer 4, Nate, is going to maintain control of the head of the spine board. In a streamlined movement, Joey's going to call the commands, and we're going to make one movement to move the patient towards the doorway. Whenever you're ready.
1, 2, 3.
Joey's going to hand off manual stabilization to Lieutenant Richardson. They're going to be very careful to keep him in line without a lot of movement. Now Lieutenant Richardson will call the commands to move the patient so that he's properly placed on the spine board.
1, 2, 3.
And we'll make one more movement. Now that the patient is positioned correctly, we'll reassess his circulation, sensory, and motor. Move him safely to the ground. Now that the patient's safely on the ground, we're going to strap the patient in using a technique with the spider straps. These are designed for patients that are 5 foot and above. We're going to start with the V of the spider straps over the sternum. We'll go ahead and secure those to the board. Next, we'll move to the strap across the chest. The next strap will go across the patient's pelvis. Next one across the thighs. And lastly, across the patient's legs. Now we'll secure the patient's head using head blocks and straps. We'll reassess the patient's CMS and prepare for transport.
So I think the only comment I'd have on the use of the spine board is the spine board is a great device as an extrication device. You do not want to leave your patient on the spine board for a prolonged period of time, because then that increases the risk of them getting pressure sores, which down the line then becomes a problem in terms of their care. So as soon as the patient is extricated, put them on a soft mattress. The ambulance gun is good enough for you to place the patient. It's firm enough. You do not need to leave them on the spine board. You can easily transfer them to the ambulance stretcher and in the hospital in an ED stretcher, because then that becomes better for the patient in the long run. So the longer the patient stays on the spine board, the greater risk they are at developing bed sores, and this can become very dramatic down the line. So the other thing is, so once you've done, you pick up the patient, you secure the patient, you've gone through your doctor's ABCD, then the key thing is, and this is something that there's a lot of debate and has been debated for many years about whether do you scoop the patient and run or do you stay and play. So scoop and run means quickly pick up the patient, do the necessary immediate intervention, and transfer the patient immediately to the nearest most appropriate facility. Or stay on the scene and do all the fancy stuff, put all the lines and get all the things ready. Depends. So there's no real straightforward answer. So it depends on what your setting is. If you are next to, if your transport times is nearby, then probably scoop and run is a better option, especially where the patient is still actively having hemorrhage or having a life-threatening emergency that needs to get to definitive care quickly. But if you're in a rural setting, I remember having a discussion with the team in Garissa, and they're saying that transport time could easily be 40 minutes or to an hour from where they pick up the patient to the most appropriate facility. Then in that case, you want to make sure that your patient is fully stable before you initiate a transfer process. So scoop and run if you are going to get the patient to a definitive care as soon as possible. Stay and play if potentially in a rural setting and your transport times may be a bit longer, so you may need to consider stabilizing your patient a bit better before you start initiating your movement to the nearest facility. But I think bottom line both ways is time to definitive care is what your patient's life depends on. They need to get to definitive care, wherever that is, as soon as possible, because this is what actually going to save their lives. So when you're making the decision on the road as a pre-hospital provider, whether you're going to scoop and run or stay and play, please always factor in the patient and how soon you can get them to the definitive care, because this is what will actually save the patient's life down the line. But again, if your patient is unstable and you have long transport times, then you need to stabilize your patient before you start moving. Just a bit on aeromedical transport, in case you ever get involved in this. And a lot of these aeromedical transport factors are the same in transport of even a patient on the ambulance from point A to point B. The key thing, of course, is you need to confirm there are no contraindications to evacuation. Make sure you have a complete survey of your patient. If your patient is moving from facility to facility, then ensure there's no pneumothoraces, because when you put a patient in a plane to move them anywhere, then whatever air is in spaces, for example, if there's air in the chest, it becomes bigger, and this can lead to tension pneumothorax. And actually, any air-filled bubble must be filled with fluid. So your urinary catheter, you need to remove the air and put fluid in it. Your endotracheal tube, remove the air, put fluid in it, because the air expands the higher you go in flight. And again, whatever radiography needs to be done, this is when you're transporting a patient from a facility to facility. Of course, there's issues of consent. So as I said, so this checklist captures both interfacility transfers and actually just when you want to move a patient, what you need to look out to. You also need to make sure your medical equipment is checked and functioning, and you have enough power and enough reserves, for example, oxygen, when you're transporting the patient. Anytime you transport a patient, you must secure everything. Secure the patient, secure the tubes, the lines, all the equipment, because remember, you are in a moving environment and things are moving around. If you do not secure things properly, so either they will get dislodged or some of that equipment will fly off and hit you in the head behind that moving ambulance. So always make sure everything is secured and tied on properly. If patients who have casts, especially new casts, you must open up the cast, because again, if you're going in a flight, then any trapped air will expand and this will cause the patient to have a compartment syndrome. In terms of removal, deflate air spleens, said about deflating air filled balloons like your Foley catheter and your AT tube, so you fill that with non-compressible fluid. Of course, your paperwork. So paperwork, and if you're crossing borders, of course, then you need your passports and visas and everything for you, the crew, and whoever is escorting the patient. Of course, one of the things that we normally don't really do, especially in the EMS setting, is ensure that the patient understands the environment they're getting in. If there's an ambulance, or their head will be here, that's the exit. If it's a plane, same thing, where the exit routes are in case they need to exit by themselves, if that's possible. And then plan around ground ambulance from where you are to the plane, and from the plane to the facility. I think it's paramount that you always ensure before you move a patient, you must ensure that the other facility where you're taking the patient is ready for the patient. And this involves you communicating ahead, making sure they know the patient is coming, making sure all the clinicians know the patient is coming, making sure there's a bed available for that patient before you even start your movement process. Of course, you need to make sure you have all your medical records with the patient, and all the plans and documents and drugs and anything that is medically relevant for the patient must accompany the patient, and must counter check this before you move the patient. Always check if there are any altitude restrictions. This is more where you do not want to sometimes fly too high, because there may be challenges that. So this is something you need to check with your flight crew. And then, of course, plan B, and plan B in case something were to go wrong. So a couple of things that any patient movements or physiological alterations during transport, whether you're moving in an ambulance, in a boat, in a border ambulance, or in an aeroplane, noise, the lights, the sirens, the noise environment can be very disorienting for a sick patient and be exhausting, and can trigger vomiting in some settings. So as much as possible, try and figure out, and sometimes you just actually just have the patient get earplugs, because also the noise also becomes a hindrance in terms of communication and also assessment. So if you think you can listen to if a patient has a pneumothorax in a moving ambulance with a siren, then I think you must be quite special at that. So always factor in what assessment you need to do before the noise starts, and what communication you need to do before the lights and the sirens come in place, and all the other noise factors that come in. Vibration, this is very much, again, with all the potholes in some of our roads, and even on a flight, all the vibrations from the rotor if you're flying a helicopter. This can easily cause your patient to move around, can dislodge, can cause pain, especially if there are fractures involved. And this is something you have to factor in, make sure your analgesia is good, because some you can avoid, some you can't avoid. So you must make sure your patient is secured, patient has adequate analgesia, and as much as possible, try and ensure that you can minimize the vibration effects on the patient. Acceleration and gravitational forces, these ones are mainly with your flights. So as you take off, remember, because of that gravitational force, if your patient, for example, has a head injury and the head of the patient at the tail of the plane, as they take off, the blood flow can move back to the head, increasing intracranial pressure. If your patient is shocked, then you probably want to have them in that position, because then you have more blood pulling towards the vital organ. So you need to factor this in as you position your patient, especially in an airplane on takeoff and landing, so that you can use the gravitational forces to your advantage. So if it's a shock patient, to pull blood to the vital organs. If it's a head injury patient, to pull blood a bit away from the head sometimes. All right, again, temperature. This is regardless whether it's a plane, on the ground. It's June, July right now in Nairobi. So if someone has been in an accident, they are cold, they are bleeding and losing all their heat protective mechanism. So keep your patient warm to minimize the effects of the cold, their bleeding. And again, humidity is mainly when you're flying. The air can get a bit dry, and your patient will then have dry secretions, and this can block your tubes. So always aim for humidity, humidifying any air that you're giving in an aeromedical transport. I think I've discussed altitude. The higher you go, the colder it becomes, the less oxygen you have available, so your patient most likely will need oxygen supplementation. And if there's any air trapped anywhere, then that becomes bigger and can be catastrophic. So always make sure you factor this in from the ground level before you move your patient up. So the art of EMS handover, this is one place where patients, we've had situations where EMS just come and dump the patient in the emergency department. No proper handover is done, and no one knows exactly what happened before the patient got there, and no one knows anything about the patient. EMS handover is one big area where, if not properly done, many patients fall through the cracks, and many patients then end up suffering purely because, so all this good stuff that may have been done in the pre-hospital setting gets lost because there's no proper handover. I've been in a setting where EMS brought a patient with very critical information that was not transferred to the team on the ground, and the team on the ground took a different tangent in patient care, and of course then there were issues in terms of the outcome of the patient, purely because this information was missed out from the EMS crew. So for anyone working in the emergency department, take a stop, listen to the EMS. They have a lot of information. They've been with this patient for probably a very long time before they showed up to your doorstep. So you need to receive this handover critically, because the information they have is crucial for the management of the patient moving forward in the emergency department.
Hi, I'm Chris Saballero. Thanks for joining us. You know, our job as EMS providers is to fix the patient's problem, get them the definitive care so the doctor can fix the system. Well, as we get the patient out of our ambulance and into the ER, this is a very important process to that patient care.
They'll get you situated and take care of you, find out what's going on.
One of the things I like to do as a paramedic is I like to tell the patient what they're going to experience as they get them into the ER. Remember, this could be a very stressful time for them, and giving them as much information as possible not only builds your rapport and credibility with them, but it kind of gives them an understanding of what they can expect as they go into the facility. You know, as we enter the hospital, one of the important things as we get our room assignments is to stay with the patient until we give a patient report. And this is what's really important, because if we wander off and we leave that patient, one of the things that could happen if the patient gets hurt, we still have some liability there. So stay with the patient at all times until you can give a report. One of the things I want to bring up to you is sometimes we come across some angry staff in the hospital, and they kind of talk to us maybe unprofessionally in front of those patients. Well, one of the things that you hear a lot of is, why'd you bring that patient here? Well, one of my favorite comments is, because this is a great place and they're going to receive some great care. And then after that, I like to take the nurse aside to say, that probably wasn't the best time to bring that up in front of the patient. But remember, we're that patient's advocate, and we need to ensure that they're going to get that good care, and we kind of stand up for them as we need to. Well, one of the things as we give our patient report is we want to be able to give a nice, brief, concise report. They're going to have our patient care record. A lot of times, they may not even listen to what you're having to say, but you want to be able to be accurate, brief, and as clear as possible as to what you came across, what you did during transport, and if there were any changes. Of course, patient history that's pertinent, as well as any allergies to medications. Again, a very important component. After you've given your verbal report, go ahead and close with the patient. Say goodbye to them. You've just done a good job of establishing a rapport and building confidence. So say goodbye to them. Hope that they feel better. And of course, get those necessary signatures from the patient as well as the nurse. You know, when we think about the patient handoff is very important to concluding our call. So we want to make sure that we give a good, concise, and brief report to the nurse. We want to make sure that we get our signatures, leave a report at the hospital at the time of service, as well as ensure we say goodbye to that patient. I'm Chris Saballero. Thanks for joining us.
All right, so the Atmos handover is a quick handover for EMS providers. It takes 30 seconds to actually give this handover to the healthcare providers, and preferably they should also be documented. So Atmos stands for the age of the patient, the name of the patient, so which is the demographics of the patient. So the key is the time of onset for the incident, so what exactly happened at what time. Then the mechanism, if it was a trauma situation or the medical complaint, what is the patient, why is the patient coming to the hospital? So getting that information. And then injuries, if it is again a trauma patient, then you want to look at the injuries or past medical history or relevant medical history in terms of information related to the complaint. So they've been having diarrhea, maybe the diarrhea is bloody, maybe there are fevers and things like that. And then what signs and symptoms do we have? Vital signs comes in, so your respirates, SpO2s, heart rate, blood pressure, GCS, level of consciousness, temperature, and then if there's early warning scores you've done. But again, which key symptoms that the patient is presenting from your assessment. So remember, key symptoms and also signs in case you picked up any. Treatment means what exactly have you given in between from when you pick them up? Have you done any interventions? Have you given any medication? And has there been any deterioration of the trends to the patient? And of course, again, at the end of it, still part of like your sample history is your allergies and prescribed medication. So it takes 30 seconds to do this handover, and proper documented handover would be a quick way to transfer the information from you who's bringing the patient to the emergency department crew for them to continue managing the patient. So I think I've discussed previously in the previous slides about interfacility transfers, but there are key important things when you're considering any transfer of a patient from one facility to another. I know most EMS providers currently do a lot of interfacility transfers, and the key important things to look at is decision to transfer. Why is this patient being transferred? Is it necessary to transfer them now? What is prompted the transfer? And then, of course, where are they going? Do they know where they're going? Do the people who are going where they're going, do they know this patient is coming? Is there a bed for the patient? Are they expecting the patient? And this has to be all the way from the ED to maybe the intensive care unit where the patient is going. So that's very important to factor in and have that information as a pre-hospital provider. So why is this patient being transferred? What prompts the indication for transfer? And where are they going? And do the people who are transferring the patient know the patient is going? Because sometimes the orders may have been given by someone else, and you're coming to pick up a patient, and no one knows that this patient is leaving. So that information is very important. Also, where you get to, and then they're asking you where you're coming from. So that communication needs to be verified before the patient leaves whatever facility they are at. In terms of stabilization, again, make sure your patient is fully stable. Take your time to prepare the patient, gather all their documents, paperwork, drugs, all the information. It's never an emergency to move a patient from one hospital to another. You need to take your time to make sure, because there's no way, you don't want the patient to crash on you in between. So if there's resuscitation needs to happen, it needs to happen in the facility, because sometimes it's very hard to resuscitate the patient behind a moving ambulance. Mode of transfer, so this needs to be discussed. Are we moving by air? Are we moving by ground? Have all the necessary plans been made in terms of the ambulance being available, the right type of ambulance, because again, is it a basic life support ambulance? Is it an advanced life support ambulance? Is it a critical care ambulance? Are they moving by air? And is the air also, are the crew trained appropriately to manage this patient? Are the crew resourced appropriately to manage this patient en route? Who's coming with the patient? What's the relation to the patient? Where are they coming with the patient? Where are they going after they bring the patient? So some people may be bringing the patient, but they want to be taken back home. Okay, so you always have to factor that in. So who is accompanying and why, and do they really need to accompany? And again, check your equipment, check your drugs, check your monitoring, package all this way before you leave the facility you're transferring. And of course, all documentation that belonging to the patient must accompany the patient as they move through. So I think just to summarize, I promised Lillian today I'll be number 8. Just to summarize, I think the first and most important part is safety. Safety, 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 safety. This is paramount and will save your life, life of bystanders, life of the patient, and pretty much help you work in a safe environment. Dr. ABC, so danger, response, control any catastrophic hemorrhage, airway, breathing, circulation, disability, and exposure, which is standard in the last part of it. And time to definitive care is life-saving, so always try to factor this in. It's time to definitive care does not mean you drive like a maniac, does not mean you drive recklessly. Okay, remember, still go back to safety. Key thing is you need to drive. Yes, there's an issue of speed, but your safety still comes first. Dying in a road crash behind an ambulance is not a cool thing. So time to definitive care is important, but again, this does not open it up for people to be reckless. In terms of handover, ensure you do a proper handover. So do a proper packaging of the patient prior to transfer, do a proper packaging of patient, even if it's from the road. But at the hospital, do a nice Atmos, age, time, medical information, issues around injuries or issues around the major complaints and the symptoms, and of course, treatments received and treatment given en route. Okay, just to mention, so a lot of the devices that you've seen here should be behind an ambulance. The additional, so ventilator, as I said, an ambulance is a mobile emergency department or a mobile critical care unit. If you're an EMS provider or very interested in EMS, so this is not even a sales pitch, I think you need to go to MedSurg. MedSurg is a Museum Hill Center in Nairobi. They have all the devices you've seen in this video here in Kenya. So they are available. So a lot of people think these devices are only in the West. Everything you've seen today is available in different settings. But if you go MedSurg, they have a whole workshop floor of all this equipment. And Alex, who runs the place, will be more than happy to show you some of these devices. So they got the Weinman ventilator. So this is a very cool ventilator. We're playing with it today earlier. But all the other devices that are available. So check out MedSurg at Museum Hill Center for all your EMS stuff. Most ambulances must meet the appropriate criteria.